What are the risks of radiosurgery for acoustic neuromas?
So while we typically associate radiosurgery as a outpatient non-invasive treatment, there are certain issues that patients need to be aware of if they undergo radiosurgery treatment. The first expectation is that radiation can take several years to kill the tumor. So this is not a quick fix. I usually tell patients 2 to 3 years for the tumor to fully die from the radiation. We know that as the tumor dies, particularly during the window between 6 and 18 months after radiation treatment, we know as a tumor dies, it can release inflammatory factors. A dying tumor becomes leaky and releases inflammatory factors that can irritate the surrounding brain. So this can cause some inflammation and can result in a flare-up of some symptoms. So if a patient, for example, has tinnitus, if they have inflammation from the dying tumor, they may have further fluctuations in tinnitus. So those patients that have tumors that die very rapidly after radiation are typically associated with more inflammation than those patients whose tumors die more slowly. So when you're undergoing radiosurgery for acoustic neuromas, ideally you want your tumor to die a very slow, gradual death with minimal inflammation. This is not a situation where faster tumor death is better. We also know that because it can take time for the radiation to kill the tumor, it's possible in some patients that hearing may deteriorate over the same time period. And there is always a question of, well, did the hearing deteriorate as a result of radiation, or did it deteriorate despite the radiation? And we all know that other factors are related to hearing decline over time, such as increasing age of the patient. So when I counsel patients on radiosurgery for acoustic neuromas, I always say that, the radiation doesn't necessarily guarantee preservation of hearing, nor does it necessarily accelerate hearing loss. But your hearing essentially could deteriorate over time, even if the tumor is killed with the radiosurgery treatment. And again, that's because there's so many other factors that can impact hearing as we all get older. The last risk that we typically discuss with radiosurgery for acoustic neuromas has to do with the facial nerve. And we know with surgery that's the primary nerve that we worry about preserving with surgery. With radiosurgery, the risk to the facial nerve is almost negligible, meaning that you can do radiosurgery in nearly all patients with acoustic neuromas with an extremely low chance of facial nerve injury, which would result in facial weakness. This risk is much less than 1% and compares very favorably to the risks of facial nerve injury following surgical resection.